Thank you, Madam Chair. Let me say first that this resolution just moves us forward into the process. And while I would have chosen a different path and have suggested a different path, that's all it does. We then come back and start looking at things. I wish, and I would hope that they might offer it somewhere online, the sale of the Democrats' magic crystal ball, because I'm hearing numbers, I'm hearing things being said that just aren't happening. Furthermore, Madam Chair, if they want to come back and criticize our final product, have at it. But we don't have that final product. None of this stuff is written into stone, and yet I'm hearing things about us kicking disabled and children off of food stamps, gutting Medicaid, et cetera, and none of that is on the table. Now, we are in Washington, D.C., and we can have differences, and numbers will lay on the page and let you interpret them in different ways. In Medicaid, as Chairman Arrington pointed out, if you make efficiencies, because when we're talking about a budget resolution and ultimately reconciliation, we're looking out over a 10-year period. And if you say that we're locked in with the hyperinflation because of the inefficiencies that we've had in Medicaid, and I'm going to take a minute to explain that in a second, over the last few years and for some time, and merely changing that growth pattern slightly is somehow a cut, then I guess you can call it a cut. But it's not a cut. It's bending the curve on the inflationary factors in Medicaid. And how we get into that, Madam Chair, is, and I serve on Energy and Commerce, so we've been looking at this and studying it. And how we get into that is that because right now Medicaid is you charge the fee, the state sends the fee to the federal government, and depending on what your FMAP, what the federal government, state government share is in your state, different money gets sent. But if it's an authorized expenditure, no matter what the cost is, the federal government is paying its share, whatever that is, and it changes from state to state. In Virginia, it's 50% for regular Medicaid, and of course 90% for Medicaid expansion. We automatically pay it. So there's no incentive for the health care providers, whether it be a hospital or the Federal Qualified Health Centers, to find any efficiencies. And it's always hard to sit down and try to figure out how you're going to do this. We're looking at a lot of different concepts, but part of what we're looking at is empowering the facilities to find efficiencies. And the cap, and I think everybody's well-meaning in this, but to correct a statement that was made earlier that somehow we were going to cap your lifetime benefits, that is not even being talked about. I don't know where that came from. It's just a misunderstanding. The cap means that we're going to cap the amount per year per individual, and then add to it an inflation factor. And because medical inflation in a whole, Medicaid outstrips medical inflation outstrips the regular inflation, CPI, so that we're not trying to keep, to make a cut by having inflation eat it up. Energy and Commerce is looking at medical inflation +1 or +2. That has not yet been determined. And just capping the amount per patient that goes to a state or to an individual healthcare provider. That then gives the state and the healthcare providers incentive to reduce the extraordinary increases over a 10-year period. And so I guess we're back to that. If you reduce, no, let me finish.
Sure.
If we reduce the increase that is projected, not actually on the table right now, but projected out into the future, that's a cut. I guess, I've never bought that argument, but then I guess you can say there might be, in theory, some reduction. But it's trying to make all of these facilities more efficient, because here's what my hospitals tell me, Mr. Chairman, Madam Chairman, and my healthcare providers. They understand that if we don't get the growth rate of the increases, not the basic program, but the increases and the fact that Medicaid inflation is outstripping all other medical inflation and the CPI, the regular inflation. If we don't get that under control, the entire system will collapse at some point in the not too distant future. So what we're trying to do with this is both make the government more efficient, but also to make our delivery system more efficient. We're not trying to cut any benefits. We don't want to cut any benefits. We just want to make the system more efficient, and by doing so, we can find savings. Now, if that's not what we do in the final bill, feel free to come after us. But the fact that people are afraid that we're cutting Social Security, as far as I know, not on the table, that we're cutting Medicare, I know that's not on the table, that we're cutting Medicaid benefits, not on the table. All we're trying to do is to make the system, over a period of 10 years, more efficient and create savings thereby. So that's where we're at. And so I understand that there's concern, but people shouldn't be being scared that their benefits are going to be cut, or that their hospital is going to close, or that the federally qualified health centers won't be out there. In the state of Virginia, my district has more federally qualified health centers than any other congressional district, by far. In my district, under Obamacare, I lost 2 hospitals. One has reopened. One has been able to reopen, modified and renovated, and so it doesn't do everything it used to do, but it's still there. And before that, people had to travel, because it was shut down under the Obamacare policies, had to travel an hour to see whether they had indigestion or a heart attack. And now they've got a hospital back there. But so I don't want to damage any of that. And we're working really hard to do that, but we also don't want the system collapsing somewhere in the not so distant future. With that, Madam Chair.